So the PREVENT study itself was a randomized controlled trial. And in comparison with placebo, Eculizumab reduced the risk of relapse by 94%, which is remarkable. So that means you may experience a relapse once every more than 60 years. And the average onset age of NMOSD is about 40 years. And then if you are treated with Eculizumab, your next relapse may be when you are over 100 years. You may not exist anymore. So once you start this treatment, you may not experience any further relapse in your life. That's remarkable. But on the other hand, it inhibits complement, and complement is critically important to inhibit meningococcal infection. So there's a increased risk of developing meningococcal infection in patients treated with Eculizumab. So all patients should be vaccinated for meningococcus prior to the first dosing of Eculizumab. And but during the randomized control trial, and to my knowledge, in the open label extension as well, there has been no meningococcal infections reported in the patients treated with Eculizumab. And as for long-term treatment, based on the recently published paper, 94% of the patients treated with Eculizumab were relapse-free at 3.7 years or something. And about a third of the patients, or more specifically 37% of the patients treated with Eculizumab were able to discontinue or reduce the dose of other immunosuppressive treatment, which is important to avoid adverse events associated with other immunosuppressive treatments. And those are the main points of the open label extension. And by the way, in addition to the add-on therapy, Eculizumab was evaluated as a monotherapy. And it has been shown to be very effective as a monotherapy as well. So you don't have to use any other immunosuppressive treatment. So you can avoid the adverse events and long-term adverse events of other immunosuppressive agents. So Eculizumab seems to be effective as a monotherapy as well. Although the risk reduction was significant, it is a fact that some patients do experience relapse while they are treated with Eculizumab. For example, in Japanese population, 3.5% of Japanese people have been found to harbor C5 missense heterozygous variations. With this genetic mutations, you cannot expect the therapeutic efficacy of Eculizumab because the genetic variation is very close to the binding site of Eculizumab on a C5 molecule. Eculizumab is not a cheap treatment. So, and with this mutation, you cannot expect the therapeutic efficacy. So this mutation should be tested prior to the first dosing of Eculizumab. But this mutation have been found in 3.5% of Japanese people, as I said. 3.5%, 1 out of 29 patients, which is not extremely rare. And it has also been shown to exist in other East Asian populations. However, generally speaking, this mutation has not been found in Western patients. So this may be an issue in East Asian patients with NMOSD, but this is critically important for us to find non-responders before starting the treatment. So this is critically important for us.